People here already. It's a couple of minutes past 1, so I will start. I'm Katrina Davis. I'm a GP and I'm also one of the directors of Greener Practice. And today we are absolutely delighted to be able to share this webinar or introduce on the webinar Dr. Katie Hawkins and Dr. Helen Frost, who are going to tell us all about their web-based toolkit, which has been designed to improve the engagement with green social prescribing for older people living in deprived areas. Before we go into the talk, I'll just give you a little bit of a background to Greener Practice because there may be some people who don't know about it. And also I've pulled out a few of the quality improvement projects which we have as part of our Greener Practice platform. So hopefully this will work. Can you see this? All good? Yeah. So Greener Practice, we are a network across the UK. We are working towards making primary care more sustainable and trying to help people working in primary care to become more sustainable. And just before we have Helen and Katie's presentation, I thought I'd pick out some of the relevant quality improvement projects that we have on our Network Plus platform. So it's basically our website, which we had some funding from the Small Business Research Initiative grant about 18 months, 2 years ago now, to create a set of quality improvement projects which would make it much easier for practices to just take off the shelf to be able to make a difference in their practices. And there are many different ways that there are benefits from using these quality improvement projects. It may be that it's helping GP trainers and trainees because they're immediately accessible and people can choose out of over 50 different quality improvement projects. And particularly for today's talk, I thought that I would make sure that there were some things that could whet your appetite that is on this platform. So if you haven't already, please do sign up for free to be a member of our network. I filtered, so in the Network Plus, which is where the quality improvement projects and the resources, over 100 different types of resources, to make it as easy as possible for practices to start making these changes. I ticked in the filterable options, the benefits, so to boost nature, improve health equalities and staff well-being for this particular talk. And then we've got a number of different practices which have come up. So for example, different quality improvement projects. So for example, non-pharmaceutical prescribing for depression and anxiety, creating a GP practice garden, becoming an active practice, boosting physical activity, setting up a walking group for patients or staff, and increasing referrals to social prescribing. Most of these are case studies which have been created by the practices where they've already done them, so we know it works. And if you go to the toolkit and you click on, for example, the creating a GP practice garden, you'll get information about the CQC areas that it will help with, also how long it'll roughly take, and which staff members can do it, and which parts of the Green Impact for Health toolkit it would apply to if you're looking for points to become bronze, silver, gold, platinum there. And then it gives you some information about what the benefits for patients, practice and the planet are. And these have been standardized. Each of the quality improvement projects have been standardized, and they usually have a case study. So this one was written by the people who'd created the Vauxhall Health Centre pocket garden, which is absolutely beautiful. And in order to be able to keep going with this website, we have had to put a small fee to get to these quality improvement projects. We're not for profit, so it's not going into the pockets of the directors. This is very much going towards running the website and continue to expand and improve what we can offer. So if you were a single person as an individual wanting to join, it'd be £30 for the year, but organisations, depending on their size, can also join. And we've set a number of users depending on the size of the practice, and then that gives you the annual cost, which actually is pretty good value, considering that it's about £20 for a person to be able to access 50 different, over 50 different quality improvement projects, which can often save money for practices as well as improve the staff morale and reduce the amount of time that people are spending on things, because we've made it as easy as possible. So there we go. If you have larger organisations than those, do get in touch with us, but otherwise you'd be able to join in that way. So I'm going to stop sharing, and I will now hand back over to Helen and Katie and let you show us what you've been doing. Thank you.
Thank you very much. I'll just share the presentation link. Can you all see that? Is that coming up? Great. Okay. Well, thank you very much for inviting us to speak today. Katie and I both live and work in Edinburgh, a beautiful city with lots of lovely places to walk and be out in nature, but unfortunately not all accessible to all, which is partly what we're going to be talking about today. So before we get started, we just wanted to introduce ourselves. So if we start, I'm just going to hand over to Katie briefly.
So hi, I'm Katie Hawkins. I'm a GP working in a primary care service in Edinburgh, serving people who are homeless. We have our own nature prescribing programme, but I've had a clinical advisory role in the Deep Green project, which we're just about to share with you. I'm also the RCGP Scotland Climate and Sustainability National Representative since autumn last year, and a member of Greener Practice Lothian and the Scottish Deep-end Group. I thought I would just put a slide to think about how green social prescribing fits in the context of Greener Practice. And we know that the greatest impact on the environment we can have is in primary care is in prescribing, with 25% of the NHS's total carbon emissions due to medicines. And we know from studies, particularly in Scotland, that 10%, at least 10% of the total number of prescription items in primary care need probably not have been issued. And it fits very well into all of the 4 principles of sustainable healthcare. We've got evidence that it contributes to preventing both physical and mental health illness, and it can enable patients to take responsibility for their health as part of self-care. And of course, it's a low carbon alternative. And I'll just take this opportunity to highlight that the Royal College of GPs, along with the Royal Pharmaceutical Society in Scotland, we've just launched a manifesto for health and climate ahead of the Scottish elections in May 2026, so this year. And one of the key goals as part of that is to enable green social prescribing. So watch this space. I'll hand over to Helen to introduce herself and the Deep Green project.
Thank you, Katie. So I'm a researcher working at the Advanced Care Research Centre at the University of Edinburgh. We've been working on innovations for older people, but I trained and worked as a physiotherapist for 14 years, alongside carrying out research in health service research and public health research. So I've got a kind of mixed background, but I've had a long-term interest in keeping people active, with a focus on health inequalities and ageing. And latterly, I've become very interested in green social prescribing, but I was fairly new to this a few years ago, so I was on a massive learning curve. So what we're going to do today, I'm going to have go over a brief background to Deep Green and the evidence for green social prescribing, talk about how we developed the website. We have 2 work streams, firstly looking at barriers and enablers to green social prescribing and how we co-designed the website. And then the second work stream, which is a feasibility study of using the website in practice. And then I'm going to hand over back to Katie, which is going to be much more interesting, I'm sure, on her perspective of green social prescribing and using Deep Green in practice, and then briefly talk about our future plans. You may wonder where the name Deep Green came from, and we thought long and hard about this, but this was so that it's sort of linked with some of the deep end practices, which are the 100 most deprived practices in Scotland. So we quite like the idea of combining deep with green, so we came up with this name. So there's plenty of evaluations out there, mainly a lot of small scale pilot studies that have looked at green social prescribing, but also I'm sure you'll all know about the national evaluation, which was a £5-6 million project of 7 or 8 test and learning sites in the UK and England. But in Scotland, we've had some 2 or 3 smaller projects. What I want you to have a quick look at now is just look at those photographs, because I'm going to come back to images later, because it's another project that we've been involved in with our collaboration. And it's one of the problems that we had, again, not problems, one of the things we had to really think about in developing the Deep Green website. So coming on to the benefits of green social prescribing, we know there's a lot of benefits out there. I'm not going to go through all of them, but a lot of the evidence is around association. So if you've been in nature, you're more likely to be less depressed, less anxious. There's not as much evidence around causation as in randomized controlled trials of an intervention in nature, but plenty of reviews out there that looked at physical health, mental health. And where we were particularly interested was the potential impact on health inequalities, because we know that we can provide these interventions very easily in certain areas, but what we can't do often is get into the areas where people really need it. And there's a concern with this type of intervention that we will widen the inequality gap. So there's also evidence around cost savings. If you look at the hard evidence of health economics data, that's a little bit less robust. It's very difficult to get that data. It has to be through trials. But what's being used in green social prescribing, which is probably a lot more sensible, is this social return on investment, which considers social value for every pound that is spent. And this, I'm not going to even pretend to know exactly what goes into that calculation, but there are estimates around from £1.88 through to £8.50, of which you're gaining value and savings for the NHS. So there's evidence that over the last 10 years there's been lots of papers written, and there's mounting evidence for the benefits of green social prescribing. So how did we come to this project? It was partly due to Katie's interest in this, and also our interest, having looked at various interventions that we thought would be we want to evaluate for people, older people living, and particularly living in deprived areas. This is a project that it's not just me. I am the PI on this project, but there's been a lot of people involved, and particularly Katie, also Stuart Mercer, who has a lot of experience with working in health inequalities, but also Ian McKenzie, who's part of the Lothian NHS Trust. So we applied for funding, and lucky enough to get money from the UKRI MRC to take this project forward. But it really came from a clinical need, which Katie will talk about later, that there's just not enough information out there for primary care, and also because we wanted to focus on the areas for people living in deprived areas. So we were very aware of the fact that there are other toolkits out there. We absolutely did not want to reinvent the wheel. So we looked at everything that was going on already and had a really good think about what we wanted in our website. Plenty of resources out there, but often it's difficult to bring those all together. So the aim of this project was to develop and test this digital toolkit to enable general practice to engage patients, mainly over 50, and those that living in high deprivation areas with green social prescribing. Because often what we see is, people are very keen to get involved in green social prescribing, but it doesn't tend to be from those groups. So our objectives were to develop the toolkit, to pilot this in practice, and then test the feasibility of it, with the aim that maybe we could collect information that we could then use to go forward to a further study of effectiveness. So this was our overall plan. And in fact, some of the reviewers that came back said, well, it's very ambitious and will they finish it? So we'll come to that in a minute, but we've done most of it. We've reviewed the literature. We've had workshops to explore people's views. So we've tried to co-design this website. We've interviewed people in primary care, including GPs and link workers and patients. And then we've co-produced this toolkit together, taking into account all the stakeholders' views. But we've done this with the web designer. We've also then had a second workshop to feed back on what we thought about, what people thought about it, having used it. and we're in the process at the moment of testing the feasibility of it. So that's where we're at. We had to do this actually in a way because we had to start it very quickly after we got the funding. So it's been about 18 months that we've been doing this project. We haven't finished yet. So we have got a paper that we're going to submit, and that's looking at the barriers and enablers to engagement with the green social prescribing and nature-based activities. We wanted to focus that on older people and people living in deprived areas, but again, there's not that much data on that. But we wanted to also understand factors that influence engagement, so we could help, that could help with the development of the website. So we found 45 studies from 11 countries, mixed qualitative and mixed methods papers, a Delphi study, and we combined that with information that we got from the workshop. So we had a workshop a year ago with GPs, link workers and providers of nature-based activity, commissioners and managers, and we also interviewed GPs and link workers again to get their views. So we were getting everybody's views on, you know, what was needed in this toolkit. So we tried to get it right. So that we came up with lots of mainly barriers, but also enablers. And I'm not going to go through all of these because I don't, we're time limited. But obviously for prescribers, GPs, lack of time is huge. And also it can be a low priority. So there's one GP said, I would say that GPs don't have time. 7 minutes, 10 minutes, 50 minutes will be a huge luxury. So we haven't time to do more than just sow a seed. So that first conversation for having, for talking to a patient with green social prescribing, I mean, it is a bit of a barrier for some people. There's also the issue of people coming in and very focused, and these are patients and prescribers very focused on that medicalised model of prescription. So there's people who are looking for tablets and they're not really open to anything else, and that's again a difficult conversation. One of the problems is a lack of up-to-date information about local nature-based activities. And this is something, I put that in yellow because it's something I thought we could do something in the website. We can't solve all these barriers with the website, but we were just very aware that you know, there are quite a lot of issues, but providing better information was something that we could actually help with. So it's not until staff get a better understanding that they are going to refer more. And I think that's a massive barrier. So that was one of our participants. Lack of confidence for prescribers in the perception of GSP also came up quite a bit, and some GPs felt that their colleagues might be quite dismissive of green social prescribing. Also difficulty monitoring outcomes. Again, if people don't have confidence in it, they want to know there's evidence for it. So people were quite keen to have some sort of monitoring available. So particularly in deprived areas, a link worker is absolutely, I think, essential. Very difficult to have that conversation with people who have got multiple problems and complex living arrangements. The link workers are absolutely essential. Or a dedicated nature coordinator. Having a green ethos in practice is definitely an enabler. Having policy support. What we found from the literature is that having that policy backup is helpful, but often policy has a sort of vision. It's not necessarily going to put the funds in that we need to sustain the nature-based activities. But providing education is something that we could do, and having patient-focused material, we thought we could help with the website, and trying to demonstrate evidence of positive outcomes, which is what our feasibility was trying to be about. But again, this was a quote, I think, from one of the GPs, that you don't want people to think you're being daft telling them to go and smell the flowers and listen to the birds. So we kind of got to get over that kind of sense of barrier with some people and have it more mainstream in practice. So this is, again, for the barriers and enablers for the providers. Again, there's a lack of knowledge. People don't know what it is. They don't know how to get there. The big thing for the providers and third sectors is money. They just have inconsistent funding and also capacity issues. When they do start having referrals, sometimes they have too many, and then it's too much for them to cope with, and they don't have the knowledge to deal with some of the people that are referred. Understanding the cultural needs and marginalised groups is very important. Again, lack of monitoring. Having this sustained fundable funding beyond a pilot study, and we've seen lots of pilot studies that have started, they've finished, they've been evaluated, they come with big amounts of money. For instance, the national evaluation in England, I said that was 5 to 6 million, but when that's finished, it has to be kept going, and that's the problem. So lots of barriers, but there are things that can help, and strong collaboration between the providers and the providers is I think essential. And coming on to the service users or patient, again, lack of knowledge and skepticism. People are that they're coming for their medication and you're offering them green social prescribing. So that conversation is difficult. They need motivation again. Training and motivational interviewing is something that's far beyond the limits of this project. That's the sort of thing that's needed. Obviously, there are health limitations, but there's also safety concerns, feeling unwelcome. So there's lots of barriers that can stop people going to green social prescribing, even if they're referred. Obviously, for people in more deprived areas, lack of transport, lack of quality and safe green spaces came up quite a bit. And of course, the costs incurred, but I mean, it should be relatively cheap. I mean, everybody you would think could go for a walk even, but there are, there's issues around clothing and such like, and particularly if you're going to refer to a voluntary garden or something like that. So providing equipment for people is fairly essential in those situations. So I'd say I'm not going to go through all of those barriers and enablers, but we've thought about all of these when developing our website. And what did the prescribers and providers really want? The GPs wanted up-to-date information about local activities, patient accessible information so they could download it or post or text it to people. They wanted the evidence for green social prescribing so they could share it with their colleagues. Link workers wanted information that they could share as well. And the providers just want consistent funding, which of course we can't do, but that's a big barrier. And they're not keen on having more, resources to update. So that's something that we needed to think about. So designing this toolkit, it had to be simple because we set off thinking that this toolkit was going to be just for the prescribers. But in fact, from the workshops and the interviews, it became clear that people wanted it to be available for providers, prescribers, and for service users and patients. So that, of course, made it a lot more complicated. And I was new to web design, so it's been a massive learning curve for me. But we wanted it to be suitable for mobile phones and for people living in digital poverty, so that, if you haven't got a fancy phone, you have limited data, that it would be simple and you could upload it reasonably easily. One thing that came out of this that I think is probably unique to our website that other websites don't have is that we developed a microsite. So what the GPs and the prescriber needs was something quick and easy. It could be done in a consultation, and this has worked in some cases. So we have a microsite for each practice that has been involved in our project, which I'll come to later, with a QR code or something that could just be text to the patient, and also to provide easily printable documents if people wanted something printed out. Something that I hadn't thought much about before I designed this website was appropriate images. And there's a colleague in our collaboration who's done a lot of work on this and finding the right sort of images that not just portray the sort of usual lovely pictures of people in gardens, that people feel that they can actually associate with them. So it's actually quite hard to get that image right. So we worked on that. The options at the beginning of the pathway for prescribing, this is nothing new, but there were three main options that people came up with. The simple prescription where you just suggest that people go for a walk or 3 times a week, signposting people to a specific group, which is what we could do with the website, or really for the most people, and particularly the more complex people that we were dealing with, and older people, referral to a link worker or an equivalent, in which nature-based interventions are flagged or where they can support people actually in practice, is pretty essential. And in fact, those first 2 pathways I really don't think work terribly well for this group. And also to remember that green social prescribing is a holistic intervention. It's obviously not suitable for crisis, and it's there to complement other medical care, but it can be used on its own. I mean, for sure it can be used on its own, but it is also complementing other care. So we came up with the website. We have a couple of nice videos on this website that we've created. That the one here shows Hannah King, who's a fantastic community leader and runs a lovely voluntary farm or community site in Lauriston in Edinburgh, and people can be referred to those that program through the GP practice and actually just from self-referral. But she talks about what green social prescribing means to her. I wanted to actually play these videos, but when we don't have time, but while you're online, you could have a quick look if you go to that deepgreen.scot website. We've also got GP views. Katie's done a lovely video, but we've also got a video from a GP explaining how he uses green social prescribing to help other GPs actually get involved. He was actually new to green social prescribing. He's part of one of the practices that we signed up to help with the feasibility study, and he's found it really helpful. So we also were asked to produce nature prescriptions. Now, some people hate prescriptions, but for a lot of people, patients and the GPs, they found this quite useful for something that they could just hand over to patients. And I think Katie will talk a little bit more about that later. We also produce these nature calendars, which are part of the Royal Society of Protection of Birds project. Again, that's something that you can hand over to patients to just take with them and explain to just go and walk and sit in the spot and observe nature. So again, some people find those helpful, some people don't, but we've had those available on the website as well. So these are the couple of examples of the microsite that we produce. So what happens here is that the GP can just text this information directly to the patient, or the patient can just use a QR code, and this goes straight to local activities that they can access easily from where they live. And people felt that was fairly essential, rather than just going to directing people to a website where you have to click on one thing to get to another. So this is a direct link to those nature-based activities. So we set up 4 of these for the 4 practices that we were involved in the feasibility study. So once we developed this website, we then had another workshop to say, right, what else can we do? What's the feedback? Where are we going wrong? So we used what's called the APPEASE framework that looks at acceptability, practicality, effectiveness, any spillover. And particularly, we wanted to focus yet again on the equity. You know, is it available for everybody? Is it useful for everybody? And we also asked them, if you could change one thing, what would that be? So we had a great illustrator who drew this. This is not my drawings. And so that's what we came up with. So in terms of acceptability, people wanted clear and accessible information. They felt it was accessible. They felt we've missed out on the real life cases, which we haven't got yet, but we had intended to do that. But also they felt that we should highlight that we did a survey last year of GPs, and that we found that 80% of GPs found that green social prescribing was acceptable, and they would refer if they could. So there was a suggestion that we should make more of that on the website. In terms of practicalities, most people found it easy to use, but they felt that perhaps there should be more maps and videos would add more value. In terms of its effectiveness, again, they felt that the evidence, we should condense it more and present it more confidently. So again, we need to work on that. And the main thing is we need to update it. And that's the problem with sustainability of any of these type of websites. You've got to keep adding to it. Were there any spillover effects? There was a worry that the extra website would add burden, and there should be some sort of feedback loop, considering maybe a chat box, which again, we haven't got to that yet. And in terms of the equity, people suggested that we should use Google Translate. So for people who can't actually read, and there would be some translation there, and provide more hard copies. Some people don't like hard copies, but that again was something people were quite keen to talk about. So changing one thing, we're looking to add self-directed walking maps from the exact practice that the people live in, a bit like the cycle routes. And use more dummy guides on how to prescribe nature. There's some suggestion we haven't got enough information on that. Some people wanted to encourage more use of a nature prescription plan. This is a very sort of personal thing, I think, but also one of the GPs was saying, look, if you have this plan, you put one of the stickers on, it makes it more official, and the people are more likely to actually go off and do it. Other people will argue that is not the case. There was a suggestion to include a Refer Me Now button for tracking purposes, and also this chat box, which, yeah, we need to think about that one. So Coming on to the feasibility, just very quickly, because I'm aware of time. We set up to test the feasibility of using this in practice. We managed to get 4 practices on board, 2 in a deep end practice and 2 in mixed deprivation. We wanted 30 referrals over 6 months just to see about the feasibility and whether we could record data, could we follow them up. We have struggled to get referrals. It has been difficult. We use the Green Social Prescribing tracking read code so we could monitor, even if they had a conversation about green social prescribing that they didn't have before, that we could potentially measure that. We wanted to look at baseline and 3-month follow-up using fairly standardized questionnaires like the UKRI, which is used in health economics evaluations, and the mental wellbeing score, along with questions about sleep and activity. And then we were looking to follow these up with interviews for the process evaluation. So where we're at, we have had over 30 odd referrals, but we've only managed to recruit 11 patients. People have said that the ability to text links has been very helpful, and there's more information required on the GP microsite. So we need to add to all of that. This is just an N=1 about whether a patient felt it was helpful or not, and an answer to whether did you find the deep green link useful. She said yes, definitely, because I was looking through it and it was a kind of just giving me ideas of places that I could go to and activities. But obviously there are other people that have found it useful, others that haven't found it useful. So we need to collect all that data. Just to finish, this is the analysis of how many people have actually used the website so far. So we've had over 1,800 visits. We had a nice peak in April. Maybe that was the weather, maybe that was our workshop. And again, we've got this data that we'll carry on collecting, but we're very much still in the process of collecting all the data, particularly for the feasibility study. So I'm going to stop there and hand you over to Katie, who will talk you through the practicalities of using the Deep Green website.
Hi, thank you so much, Helen. And yeah, so Helen has put a huge amount of work over and above her time into this project, which is incredible. I'm going to talk about the rationale for why I felt we needed Deep Green. And I think so many of you will be very also over familiar with Julian Tudor-Hart's inverse care law, where the inverse care law states that availability of good medical care tends to vary inversely with the need of the population served, and clearly amplified in health systems that they're exposed to market forces. However, I was increasingly aware of the inverse climate law, where those at greatest risk of the climate crisis lack resources and are least resilient to it due to the pre-existing society inequality as a whole. And as I understood this, I wanted to understand more about how green social prescribing fitted into this, but also particularly my patients very much at the deep end experiencing homelessness. And I had this underlying fear that when I noticed the wave of policy and political attention to green social prescribing, there seemed to be very little in the literature that explored how my patients and those most marginalised would fit in. And I was also concerned that something, albeit with really great intentions, might widen the inequality gap. The next slide. And so when we conceived the idea, Helen, if you can change the slide, that would be great.
Sorry, I don't know why, but it's just suddenly, oh, hang on, it's going that way. Oh, there we are.
Perfect.
Stop moving for a moment.
So, at the time that Deep Green was effectively conceived, there were 3 local evaluations published in the Lothian area, which all mention the challenges of using green social prescribing for the most socioeconomically deprived. So, and the need for more work to understand and mitigate this. So very much, as well as fitting in with a sort of national and international picture, it very much fitted in with what was going on locally in and around southern Scotland. So next slide. I wanted to really understand more about whether there was a way we could make green, so one before, I think you jumped one, Helen.
Sorry.
Okay.
Sorry.
I wanted to understand if there was a way that green social prescribing could be made accessible for those who are most likely to benefit, but also least likely to access it. And I'm going to talk about a case that will illustrate how Deep Green can be used and some of the challenges around this. But also I just want to mention that specifically that my practice wasn't one of the test sites for Deep Green, isn't one of the test sites, but we've been involved in green social prescribing, which has been evolving effectively alongside Deep Green. So I think they've both the Deep Green and what's happened at our practice have sort of learned from each other at the same time. So next slide. So a little bit specifically about using Deep Green in practice. One of the biggest challenges is selecting which patients will benefit. Some people do take offence. You know, I've definitely had patients say to me, look, I just want my medicines. But we know that the evidence is strongest for people who need support with their mental health, have complex social needs, are lonely, have one or more long-term conditions, or are experiencing inequalities. And I particularly find with my patients that they are very receptive to the idea of green social prescribing, although many of them do actually really struggle to make it along. However, I'm very aware they're all in the criteria of people where the evidence is strongest for benefit. I think, again, Helen's also already mentioned alongside other prescriptions, and I think, or other treatments, and I think that's important. It doesn't need to be instead of, but what it can do, and I particularly find that in the longer term, I notice that maybe I'm prescribing less medicines for somebody after they've been using green social prescribing for a while. Certainly, it's worth thinking about initiating any prescription. Certainly in Scotland, we have the realistic medicine approach, which has the right decisions toolkit, where it's called the sort of BRAN acronym, where we look at benefits, risks, alternatives, or do nothing. And that can be really helpful to have in mind when you're initiating any prescription. But when do I mention it in a consultation? Often it can be towards the end, which brings us on to the challenge of trying to meet the patient where they're at in their journey, which is difficult and it can take a lot of time. And what I've noticed more and more is that it's not always me who has that good conversation. I think it can be more effective if I can have that good conversation at the time when we're planning the next steps to someone's recovery or in their journey. But it doesn't necessarily have to be me. The 3 options is absolutely vital. And I think having a calendar that can be printed as well is something that's really important, because people often want something they can do alone. And I find that people are often quite afraid of going along to a group. So that can be quite a gentle introduction. I know it is something that's printed, but especially if people are living in sort of digital poverty, having something that they actually get on high quality paper can make them feel validated. And certainly the feedback I've had verbally from the calendars is really good. But in reality, as Helen said, fewer people manage to get into an activity through a self-directed activity. The people who get there usually are people who have a very much supported referral. And that doesn't necessarily need to be by a link worker. It could be through somebody else attached to the practice. The microsites, these I think are key to the success of Deep Green, because the practices actually feel as though they're part of something important. There's up-to-date information. I certainly feel I would avoid doing a prescription to a pharmacy if the medicine was out of stock and you would hear back immediately if it was. I think the same should apply for green social prescribing. But there is this, at the moment, all the links on there are up to date, but there's this long-term question of who's going to update it in the future. Is there something around community or practice ownership? Because certainly the feedback we've had is that practices find that really important. And then clearly being able to text the link to the microsite is important, but also texting the link to Deep Green itself and some of the evidence and patient information is really important. And then, of course, hospital waiting lists are really long, and green social prescribing and some of the activities on Deep Green usually have either no or a very minimal waiting list. So next slide. So other things we debated was this challenge around prescription, and we worried that it might put people off who weren't actually prescribers, actually being part of the process. But I think the word prescription is really empowering. It allows patients some kind of responsibility to take ownership of their own health with some kind of guidance. I'm aware that in Scotland, unfortunately, we don't have e-prescriptions as you do in England. So we're still handing out pieces of paper. So this is an alternative to that piece of paper, which can be handy. Confidence and permission to prescribe is absolutely massive and I think testimonials from other GPs and patients really put across the message that this is a collective vision. and certainly gives me the confidence to prescribe, and also patients the confidence to go along if they can see somebody similar to them has gone along and had a good experience. The GP survey that Helen mentioned, again, that we did, where 80% of GPs felt it was a good idea in Scotland, was really important. And I think the evidence is not just important to get other staff on board and patients on board with how powerful it can be, but it's also really important for enabling funding if you're wanting to set something up similar in your own practice. Does it mean less prescribing? I don't know, but I get the feeling that there is less of that in people who are using the green social prescribing. So next slide. I'm going to tell you a little bit, just briefly, about my practice. We're not one of the test sites for Deep Green, but as I've said, some of the things we've done have contributed to the evolution of Deep Green. We have a similar option. We have self-directed calendars, which you can do alone or with support, and we changed the language of the RSPB calendars to be very much to sort of that you needed a much lower level of literacy to access them. And we felt it was very important that people did not need a mobile phone to access those calendars. And then we also have garden-based activities just with a practice garden outside the practice, which you can see at the bottom of the screen, which used to be a playground when we moved to our new practice site. And that's been developed over the last few years, luckily with a huge amount of support and funding, as you can see the organisations below. In the garden, we have a hot drink and food as well alongside activities. And certainly the garden isn't just used for gardening, it's used for multiple other things as well. And then for people who are feeling a bit more confident, they can be referred into a woodland programme, which is in a nearby woodland that they go along for 12 weeks, called Branching Out. We've had an initial review at the point where actually virtually nobody turned up when it first started. And then an evaluation, which is much more comprehensive, published last year, where we've got views of lots of practice and lots of patients and staff. I'm now going to tell you about John. He is, I've changed his name and anything that might identify him, but he's a man who's recently become homeless. He was sleeping rough until last November, but now he's in a nearby hostel. He struggled with addictions all his life and spent a lot of time in and out of prison. To be honest, when I see him, it's hard to understand how he's survived all he's been through. Amazingly, for the last 10 years, he's been stable on his methadone script. He's been homeless before, but this time it seems different. He has COPD. He struggles with the stairs up to his room in the hostel he's been allocated. It's harder for him to make all his appointments for housing and health. And when he sees me, he seems sad. He's fed up. He's not been leading the life he thought he would live. I discuss our nature plans with him. However, he seems at this point receptive and even talks about the garden he used to have. However, I'm already running late, as usual. I don't have time to go into this in more detail, but I do ask him to take a look at the garden on his way out. He doesn't have a working phone, so would struggle to access the Deep Green website as such, but I do print out the calendar of activities and a nature prescription. I ask our mental health nurse to get in touch with him, and she introduces him to our link worker. They get to know each other, and after a while he feels comfortable to start coming to the garden. Initially, he just comes and takes away some food, but now he's been 5 or 6 times and started to get involved in the gardening. Last week he showed me the bag of herbs he had collected to take back to the hostel to add to his meals. He's now thinking about signing up for the next Branching Out programme. He feels as though he now has more purpose in his life, and he's somewhere where he can go, where he doesn't feel excluded, away from the pollution and busy street, and has some reprise from the stigma of being homeless. So the next slide, it shows a few quotes from John. And I think, as Helen alluded to, lots of patients do talk about their past life and things that happened in their childhood. And for him, specifically, stigma is important. You don't feel moved on or shifted on. It literally says on the wall, stranger, you'll do well to linger here. Everywhere else is going, move on, move on. Have you paid for that? Get out. And a place where there's respect. But I think specifically for John, although it's beneficial for him, it's involved an immense effort for multiple staff members in getting him there, even though it's actually our own practice garden just outside the back door. And we have the incentive of free food and drink every week. I don't know what his long-term engagement will be like, but it's amazing to see him talking so positively about it. So on the next slide, I'm just going through a couple of thoughts from our evaluation, which tie very well into Deep Green and do have a few quotes. The importance of prescribing programme being flexible is absolutely vital. And certainly it's been shown to improve participation rates. And it did particularly happen like that with us, whether that was more so because our patients were homeless. Stigma, again, as in John's case, he did feel accepted, but it's not always the case, especially if you're not from the UK, and the stigma which comes with homelessness, substance use, or sometimes mobility problems, particularly if you're elderly. And we've had a lot of people talk about the fact that, you know, for example, somewhere where some people might say, oh, well, go along to the Botanic Gardens in Edinburgh. And I've certainly had a patient say, well, that's not for me. I can't go there. That's not my kind of place. So just next slide. And then the other thing that's just key is that relationship first. And I think that the feeling that you can't just refer someone and expect them to turn up. And particularly for somebody like John, he needed that extra support. And also age comes into this as well. I know he's only 62, but he's clearly biologically a lot older than he is chronologically. Food, a massive gateway for people coming along, and seems to be a starting point for most people who come into our garden. Are we still widening the inequality gap? Well, we're hoping that we're doing something to mitigate that. But I expect there's a lot of people who are like John, who really never get to the garden or never get a green social prescription and wouldn't be able to make use of Deep Green. And I think that's why we've been quite careful with Deep Green, that it's not something that's suitable for people in crisis, and particularly when they're homeless or somebody's homeless and has the immediate crisis of food, sleep and housing they've got to deal with. So next slide. So reflections on Deep Green social prescribing at the deep end. At our practice, certainly I found that the team approach is massive, and just remembering that it doesn't necessarily have to be me or you as the clinician that is the person who's the enabler to getting somebody there. Getting colleagues on board is actually probably the most challenging thing I've found in my whole journey of green social prescribing. And that's due to various of the reasons, some of the reasons that Helen's alluded to. We actually had a wellbeing nature session for all our staff without patients just last week, and I think that was really helpful for some staff to see some of the benefits of what we're doing. IT, always a problem in the NHS. It would be really helpful to try and get more staff to code when they do prescribe, as I think a lot of people are often doing it but not coding it. It would certainly be helpful for evaluation, and it would help if it was integrated into our computer systems. I just want to reflect about a few things specifically to John and homelessness. So people who are living in the most extreme deprivation have less access to green space, but often it's not just the green space, it's a green space where they actually feel safe. And this is particularly more important if somebody's got something else like age or homelessness, which makes them feel more marginalised. For John, I was very aware that the only outdoor space he had access to was going outside his hostel and onto one of the busiest junctions, vastly polluted with someone with really quite severe COPD. So having our garden is a really important thing for him. And then when homeless comes into it, having often people who have slept rough may have a more complicated relationship with nature. So next slide, just a final few words on what are the next steps for Deep Green. Ultimately, I think the ideal would be to try and make green social prescribing at the deep end through a mechanism like Deep Green core practice. How can we do that? We need permission. Often staff feel it's something they need to do in their own time, and I've certainly found that. And there's no real incentives or enhanced services to help. So what would help clinicians who are sort of feeling on the fence about it, especially in deprived areas, more inclined to use it? I think certainly some of the QI projects that Katrina's alluded to are a really great first step, But certainly sharing these ideas through, I think, the equivalent of what we have in Scotland as clusters to primary care networks in England is important. Training, we know it works, but we're increasing the opportunities for people and for staff to understand about how and why it works, and enable people to feel confident to use it. Evidence, again, massively key, and it's also just that important point that the funders want it as well. And also, we don't know how the best way to make sure green social prescribing doesn't widen inequalities, but we're hoping that deep green goes some way to mitigate that. Again, we've talked about equitable resourcing, especially for somebody like John. And this is only the start of what needs to happen. And that equitable resourcing needs to be also not just for providers, patients and primary care, but also we would ideally need more resources to make deep green more accessible to people. Again, just back to the principles of sustainable healthcare, keep it in mind when doing any prescription or thinking about a prescription. And then the next stage is we need to understand how to refine deep green in practice at all levels and we think there's a good case to do this, but if we're going to make it more accessible and more usable, we're going to need some funding from somewhere in order for it to realise its potential. So we can maintain the website until 2027, and then we'll see what the next steps are. So thank you very much.
Thank you for listening. Also a few references there if anybody wants references.
Katie and Helen, honestly, what a fantastic resource you've created. So detailed. You've thought of all of those elements that I've been toying with how to start with something like this, and you've already done it all. That it's enormously valuable. So thank you very, very much indeed for all the work you've done, but also for explaining so clearly what you've done. I know that people have questions. You mentioned their evaluation. We do need to have evaluation of these webinars as well. So I'm just going to give people, if you don't mind, 30 seconds to complete the feedback form that's there just before we start having a Q&A. So I'm going to just point that out to you. If you could just spend 30 seconds putting your thoughts into that feedback form that's in the chat, then we'll be able to know what went well, what we can improve for the next time as a greener practice. So just whilst you're doing that, I do have loads of questions, and I can see that there are some more questions there as well. I was just wondering, have you had any contact with social and therapeutic horticulture practitioners as part of this, or is that something slightly different? I think Trellis works in Scotland in the way that Thrive does in the UK. I was just wondering how that whether you have STH practitioners, for example, coming to your gardens, whether you find that might be less of a barrier for people to be involved than having to go to outsourcing places, if you like.
Want to answer that, Katie?
Yeah, I can do. So certainly both Helen and I did actually meet with Trellis when we were setting up Deep Green, which was really helpful. I think some of the challenges actually having the number of people who are trained in therapeutic horticulture versus the amount of need that there is. Certainly, we're very lucky at our practice, and we have a charity, Cyrenians, where we have somebody who is very much a gardener, but is effectively a trained in therapeutic horticulture, but not only by the nature of what she's doing, as opposed to actually formal training. So I think actually getting, and certainly we would love to have, OTs involved, mental health nurses at all stages, but it's part of that challenge with permission and funding that's needed. And certainly, particularly with the case of somebody like John, he needs all that support to be able to make use of it, which we were lucky to sort of provide in a fairly sort of opportunistic, roundabout way. But that being accessible for everyone would be a wonderful thing if people would resource it appropriately.
Yeah, there's a lot of love coming in on the chat for everything that you've described. So the first from Honey, how will you make sure that the microsites are kept up to date?
Yeah, that's a particular difficult one, but we're checking it all the time. We're keeping an eye on things at the moment, but there's a limit to my contract for starters. I mean, I've been the main driving force behind the the deep green and my contract ends, so we have to find somebody else to do that. So this is what we're looking at next, about trying to find a project that will take this forward and continue with that maintenance. But it's like any website, you have to keep those links up to date, particularly for this sort of thing. Otherwise, things, you know, they come to a dead end straight away without being able to access it. So I mean, it's a really good question. I don't know I've got an absolute answer to it, but it's absolutely crucial in having that quick and easy and definitely available access. But you know, some of the conversations we've had with some of the providers, you know, it's not good out there at the moment. They're losing funding, so that has to be, you know, it is often particularly linked to that. We have a fantastic site at Lauriston in Edinburgh, where there's this lovely garden. And if anybody wants to look at that video of Hannah, you can see all of that going on. And but they have to have funding for that.
Yeah,
and it has to be.
It's a constant battle, isn't it?
It is, absolutely.
Yeah, I did. So the link to your website is in the chat. The question regarding, I was just thinking about patient participation groups for the updating. Is that something that you've already been using, or is that not going to be appropriate in some of these settings?
Sorry, Katie, did you want to answer that one?
I mean, we've had there's been a patient involved in the whole process of the evolution of Deep Green itself and being along to many of the meetings. Certainly, I can talk about from a patient participation group about our practice. People have fed in, given we were evaluated, and that's very much then enabled the next stage of what we'll do, certainly in our practice, which has been really helpful. We haven't got patient participation groups at the 4 test sites, but I think that's mainly due to very low numbers, but it's something that would be really important for the next stage of what we do with Deep Green.
Somebody suggested maybe having them volunteering to help with keeping up these local the microsites.
Well,
yes,
I mean, got somebody actually, sorry, through the feasibility study who's very keen to get involved, and she's got some background in development actually of websites. So, but you need to find the right person for that, who's able to access all that information, particularly around evidence and well, not we wouldn't necessarily expect that, but around interventions maybe. But it's knowing what's out there, and even the best will of the world, it's difficult to know everything that's going on. That you need, somebody committed to that. And in Edinburgh we have the Lothian charity where there's information about that.
It's been something we've debated at length at most meetings we've had about about this challenge of, you don't want to refer to sort of something that's not there, and I think it's a constant challenge with green social prescribing.
I think it is for all websites, isn't it? I think we can appreciate that. So there's some ideas about working with local photographic groups to capture the types of images that you're looking for, which is a great idea. If you've not already done that, somebody suggested that to us as well. I think you've already mentioned the research on the STH peer-reviewed papers. I expect there's going to be some of that in your list of papers that you've included on the chat there. And then, somebody mentioning how John's story, that was moving. I was really moved by that story. And that's one of the big things that we know about climate, isn't it? That for us to communicate that better is through stories, individual stories. So, yeah, thank you for that. The recording is going to be available on the website, so on the Greener Practice website. So you just go to where you found this event on the events page, and then the recording will be there in the next few days. Kira Drummond saying, what are your thoughts about ensuring the long-term sustainability of programs like this? Do we need long-term patient follow-up, looking at prescribing rates, focus on economic benefits of social prescribing, improved prescriber satisfaction?
We certainly do need long-term evaluation, to be honest, before and after, I mean, in some sort of trial, but these things take time to push through, and you obviously need the money for that. In terms of a research project, could be a health improvement project, more like, but certainly from a research point of view, the next stage for us was to go on to potentially do an evaluation study, but that requires funding. which we're working on.
And I'd certainly say that with regard to what we did at our practice, we've been very lucky, and we actually managed to secure 5 years of funding. And I think that has been absolutely vital in order to actually make the progress that we've made, especially given how vulnerable all the patients are. So yeah, but a challenge always.
Thank you. And then somebody, Madeline, saying, mentioning about the Thrive have developed this Cultivating Wellbeing app. So yeah, I know I was speaking to the CEO of Thrive only last week, and he mentioned the Cultivating Wellbeing app that we can promote as well. Trellis are working with SRUC, and we'll be running some formal training courses soon. I know there's training courses on STH on Thrive. Is SRUC, I don't know what that means, Scottish something or other, is it?
It's the Scottish Rural College that do the horticulture courses in Edinburgh, and also various different places, Elmwood, Oakridge. So they are working with Trellis to come up with a formal course. I'm one of the ones waiting to hear about that formal course, because I've done the horticulture, and I'm really interested in the therapeutic side. But as you just said, there's not so many people available that are actually trained and qualified in Scotland. So hoping that course will happen this year, if not next year, but Trellis might be able to give you more information on that.
And Madeline Thomas, thank you, Caroline. Madeline Thomas, who's on the call, is a social and therapeutic practitioner. So you might have some reflections as well, Madeline. I don't know if you want to switch your mic on and show us your face. It'd be nice to see some more faces.
Oh, hello. Right. I think I've managed tech.
Yeah,
we can
hear you.
Hi. Yeah, sorry, I seem to be a bit
brilliant.
dark at the moment. Hi. A really great presentation. Thank you very much, everybody. And really interesting to hear about the project. Yeah, lots to say on it. I think as a practitioner actually delivering, I'm a freelancer, so based here in Sheffield, where I know a couple of your other greener practice directors are also based. So I'm working on a project which I'm delivering with Sheffield and Wildlife Trust, and we are hosting a number of free sessions, but we're not getting the show ups and people turning up to the sessions. I'm also hosting and delivering a number of sessions at Broomhill Library, which has been funded for Nature Connections, and again I'm not getting the referrals. And we have been promoting the service to a number of the GP practices in the area, etc., etc. So I was really interested to hear about the enablers and the barriers and what is actually stopping people turning up. And I've had conversations with a couple of people who I know are on this call, and I think one of the main issues for me is, particularly if people are suffering from anxiety and mental health challenges, actually turning up somewhere new is a massive barrier. So it's having somebody along to accompany somebody to that first session, and then they know that they're welcomed, etc. So that for me is a big challenge at the moment. So I'm being paid to deliver sessions, but I'm getting no shows, which then is going to feed back to the funders that there isn't demand. But we know that there's demand out there, and I know, and I can give you 30 stories off the tip of my tongue, like John, which just I don't need the stats for it. I don't need the medical evidence. I know it works. So sorry, a bit of a ramble there, but I could go on for a long time about it. So obviously I'm really passionate about it.
Yeah.
And sorry, do you have anything to say?
I was just going to say, Madeline, that it's really great to hear. I mean, that's certainly we've had a large number of sessions where nobody's turned up, and I think that's been part of such a massive part of the learning experience. And that's why it's certainly when we started the program at our practice, I had this diagram where one thing went to the next, and then I actually realized it revolved around, I changed the diagram completely to actually relationship was at the center, and that was, relationship, trust, and making someone safe was key. Food and drink was around the edge, and then everything else was sort of fitted in a bit sort of a bit of a complicated way that was very much relevant to that individual. But yeah, and that relationship takes time, energy, and needs the right person.
I totally
vital.
agree. I think if I can get somebody in and they know that they have got committed like 6 or 12 sessions, then I've got proof of that. Then they've stayed with me all the way through those sessions once they've got over that fear factor. I totally agree. That relationship is at the heart, and it's not just somebody knowing about mental health or knowing about plants or the right, nice, shiny environment. It's that connection, as we all know.
All the
So
best.
I think. Sorry.
So carry on, Helen.
One of the experiences in our little project is that you know, the community worker, she actually went into the GP practice to say what she could do and what she could deliver. I don't know whether you've done that, but she made an appointment with them, and they you know, they have to be receptive for that. But you're absolutely right, it's the relationship between the provider, prescriber, and that has to work perfectly well, and so that and obviously the patient. But that certainly, I think, helped for Hannah, and she is now getting more referrals, not necessarily from our practices but from other practices. So that's one way of doing it, to just, you know, just keep it at it and keep going to the GPs and say, look, this is what I can deliver, and this is the evidence for it.
I think we're going to have to wind it up there because we've just gone over the hour. I'm so grateful, and I think we've all benefited a huge amount from the work that you've done here, and hope that it will find the funding that it needs and continue to go from strength to strength. Certainly it would be great if we can embed some of your links into our website as well, to be able to signpost, and you know, hearing more stories about how individuals have benefited, I think, is a really powerful stuff. So thank you very much, everybody, for staying, and it's great that you managed to stay on for the extra few minutes. Much appreciated. Lovely to see you all. We'll see you again.